Hello, this is phacoemulsification surgery video under retrobulbar anesthesia in a patient with grade 3 nuclear sclerosis. Initial side port is made to perform capsulorhexis using 15-degree knife. Trypan blue is injected to stain the anterior capsule of the lens, and then the cystotome is prepared using a 26 gauge needle by bending it in 3 places. The bending of the needle is adjusted as per the patient's anterior chamber depth. After stabilizing the anterior chamber with viscoelastic, the prepared cystotome is carefully introduced into the anterior chamber. And then the tearing of the anterior capsule is started. It may be either done clockwise or anti-clockwise as per the surgeon's preference. The tearing of the capsule the tearing force of the capsule should always be towards the central of the capsular area. The tearing of the capsule is a bit difficult in subincisional area, but this may be easier as you are experienced with it. Additional viscoelastic may be required if there is hypotony or anterior chamber instability before you complete your capsulorhexis. After completion of the capsulorhexis, additional viscoelastic may be required to stabilize the anterior chamber. 2.8 mm keratome is used to make a clear corneal tunnel. A side port is made to pass the chopper and other second instruments. Another optional counterport is designed or made to deal with the subincisional cortical matter aspiration. The viscoelastic is then cleaned up from the anterior chamber before attempting hydrodissection and hydrodelineation. You can see a golden ring after you make a good hydrodelineation, as in this case. A phaco tip is passed into the anterior chamber. The phaco tip is 0 degree and then it is 2.8 mm. With the help of the chopper, the nucleus, after gripping the nucleus is broke down into the 2 pieces. This 2 pieces is further divided into 4 with the help of phaco and the chopper. These 4 pieces are further divided into smaller pieces before it is phacoemulsified to decrease the power of the phaco that is required. So breaking down this nuclear part into the smaller part is very important to reduce the power used in the phacoemulsification, and subsequently that decreases the corneal edema in the postoperative period. The smaller part of the nucleus are brought into the phaco tip with the help of the chopper. And finally, all the nuclear fragments are phagoemulsified. After phagoemulsification of the nucleus of the lens, the cortex is aspirated with the help of the Simcoe cannula. It is the surgeon's preference to use the Simcoe cannula, but one can use the phaco adjusted irrigation and aspiration handle to deal with the residual cortex. I personally feel very safe aspirating the subincisional cortex through the counterport. Additional posterior capsular polishing may be required if there is any pre-existing posterior capsular opacity in the patient with cataract. Our care should be taken while doing the posterior capsular polishing to avoid the posterior capsular tear and then the vitreous loss. Viscoelastic is injected after clearing the posterior capsular opacity. A single piece acrylic foldable IL is injected into the anterior chamber, and then finally the second haptic is pushed into the capsular bag. So centration of the lens is ensured, and then the viscoelastic is thoroughly cleaned from the anterior chamber and also from the capsular bag. Thorough cleaning of the viscoelastic is necessary to prevent raised intraocular pressure and corneal edema in the postoperative period. The corneal incision is hydrated, and then the integrity of the wound is checked, and finally subconjunctival injection of gentamicin and dexamethasone is given.